So we are starting the first session of the day. I invite my co-moderator, Dr. Bindiya Gupta. Dr. Bindiya Gupta is a professor at GTB Hospital and UCMS Medical College. And she has put in lots of effort for this panel. And it's my pleasure to introduce my panelists as well as my expert. Our experts are Dr. Rupinder Sekhon and Dr. Swasti. Everybody knows her. She is a senior person from Rajiv Gandhi Cancer Hospital, and Dr. Swasti is an oncologist from Max Hospital. Our esteemed panelists are Dr. Kanika Batra Modi. She is at Max Saket, senior consultant oncologist. Dr. Paki Agarwal, senior consultant oncologist from Apollo Hospital. Dr. Krishna Agarwal, professor at Maulana Azad Medical College, and Dr. Vidhu Mudgal has got busy. Dr. Archana Mishra, she's a professor from Safdarjung Hospital. Dr. Babita Shukla, she's a senior consultant from Gorakhpur. And Dr. Meenakshi Chauhan, she's a professor from Rohtak Medical College. See, we are going to talk about evaluation of an adnexal masses. Adnexal masses always dodge us. We have, as a clinician, as a gynecologist, we are always thinking whether this adnexal mass should be treated by a general gynecologist or by specialist gynae oncologist. Approach to any adnexal mass is very important. We have to take a proper history, clinical examination, investigations, which include imaging as well as the tumor markers. It is very important to risk stratify each and every adnexal mass individually. We cannot have a common parameters for all the adnexal masses. Each patient has to be seen into its own criteria, and risk stratification has to be done individually. This is a 38-year-old nulliparous lady consulted in February 2022 for a second opinion. She came with a history of amenorrhea for 1 year. She was on medical management for endometriosis. She has been taking Dynogest 2 mg daily for 1 year since February 2021. Capgolin 0.5 mg twice weekly. In December 2021, she had taken for 3 months, and serial ultrasound shows the size of endometrium was constant, 2.5 centimeter left ovary, 3.5 to 4 centimeter in the right ovary. We get these case scenarios very often because more and more girls are coming with infertility treatment and they are presenting with endometriomas and they do not want surgical management. Previous cycles were regular. Of course, dysmenorrhea was present. Had taken treatment for infertility in 2012 to 2014, IUI 10 cycles, IVF 1 cycle, laparoscopy 2014, which shows uterus, bilateral tubes normal, ovary bulky light side, and endometriotic implants present in the pouch of Douglas. Family history, diabetes in both parents, ILD in mother, but no history of cancer in the family. On examination, BMI was 33, mild pallor, thyroid and breast were normal, per abdomen soft, pelvic examination, per speculum was normal, uterus anteverted, normal size, fullness in the right fornix. TSH was normal. Ultrasound of January 2022 showed right ovary 4.4 into 3.8 into 3.7 endometrioma, left ovary 26 into 23 millimeter endometrioma. So there are dilemmas for the patient. For Dr. Meenakshi Chauhan, the patient is asking you what is the next line of management, how long she should continue Dynogest. She's worried about her amenorrhea, she's confused about her fertility, and she's also asking you what is the role of Mirena in case she decides against conception. How will you counsel her?
Okay, so regarding this patient, see, actually in 2012 and 14, she had 10 cycles of IUI and she's 38 years of age. So I think first of all, I would like to look for the ovarian reserve at least, because 38 and 10 cycles of IUI, it's a bit too much. And so I would like to look for the ovarian reserve, the AMH, also the FSH. She is also amenorrheic, though the amenorrhea can be due to dynogest. She is having amenorrhea for 1 year. Then how long should she? And then, of course, at least, especially if she is worried about her amenorrhea, I think I would like to stop dynogest. And she is, there's the issue of fertility also. So I would like to do a laparoscopy, at least for her. Though I know that my IVF colleagues, they might not like to do laparoscopy and directly want to retrieve ovum and do IVF. But I think with, in the last laparoscopy, these ovarian cysts were not there. There were some nodules in the pouch of Douglas, and it's not told that whether some clearance of pelvis was done or not, which should have done actually at that time. So it's not clear. So I would like to stop dynogest. Her menses might return back. And then I would like to do a laparoscopy and assess the both the cysts, and of course excise them, taking due precautions, of course, looking for the AMH initially, because we know, of course, with cautery the AMH can reduce. So many things are there. So now if she is not worried about her fertility, then Mirena, of course, is a choice. But before that, would also like to do some, because bilateral ovarian masses, 38 years of age, infertility, and BMI is also high. I would like to do CA125. Again, a word about CA125. All of us know it can be raised in endometriosis and raised in carcinoma ovary also. But then in endometriosis, they are usually not very high.
Thanks, Dr. Meenakshi. Dr. Pakhi, what is the evidence of long-term use of Dynogest for endometriosis? And what are the risks associated with long-term use? Do you have any personal experience?
Thank you, ma'am, for inviting me to be part of this panel. So about Dynogest, it is now becoming the first-line medical management in endometriosis, because data is accruing. Previously, when it had started, we were giving it for 3 to 6 months.
Welcome, Dr. Rupinder, madam. We are happy to have you with us.
So previously, we were giving it for 3 to 6 months, and then there was data which accumulated that it is safe for a year. And now companies have also recently released that even if it is given up to 5 years, provided the patient is tolerating it well, they have not noticed any significant decline in BMD. So there is some decline which happens after 12 months of use, but it plateaus. And once the drug is discontinued, the BMD again comes back to the baseline. The fall in BMD is generally noted in patients like teenagers who are having rapid bone turnover, so not for all populations. And sometimes there can be side effects like headache and mood swings and some irritability, which over time the patient learns to adapt to. One of the bothersome symptoms that patients have is irregular bleeding spotting episodes. So they also tend to get better with prolonged use, and almost 40% patients become amenorrheic when they are on regular treatment, and this is seen as the way the medicine is working. So if the patient is comfortable and she is still undecided about fertility, she is symptom free on Dynogest, she can continue to use it for a longer period of time, unless at any point she decides to go in for fertility or her symptoms become very troublesome or bothersome.
That's really great. I will request Dr. Babita Shukla to put a light on role of cabergoline for treatment of endometriosis.
First of all, I would like to thank Sadhana ma'am and the entire team of NIGF for inviting me on this forum. Ma'am, yes, we all know Dynogest is the first line of treatment in endometriosis, but at times the severe pain associated with endometriosis is not relieved by Dynogest alone, and we have to add on second line drugs. So cabergoline is one of the drugs which has more impact on the pain factor of endometriosis, and Dynogest helps in reducing the size of endometrioma. Cabergoline has an inhibitory effect on the vascular endothelial growth factor, and it is also, there is anti-angiogenic factor, so it helps in regression of the size of the lesion. And when we compare with Dinoges, we all know that Dinoges reduces the size where cabergoline is more effective in pain part. And when we compare it with the GnRH agonist, we see that the data shows there is 64% and 24% chances of reduction. So yes, we can add cabergoline and it gives good pain relief.
So that's great. After stopping Dynogest, this patient resumed her periods in April, and there were regular cycles, though there was dysmenorrhea was present. But she also started to experience hot flashes. Her glycosylated hemoglobin was 6, LFT, KFT and hemogram was normal, fasting blood sugar was normal, lipid profile was normal, pap smear was negative and HPV was also negative. But CA125 in March 2022 was 66 and September it was 28.
So I just wanted to explain this 6 months of gap between the two CA125 because she was just wanting to make up her mind whether she wants to conceive or whether she wants to go in for some non-surgical management only for treatment of endometrioma. That is why she just wanted to keep her on follow-up without any medication.
So now ultrasound which was done in March had right ovary showed 2 endometriomas, 46-44 as well as 41-31. And left endometrioma was 31-27 millimeter and uterus was bulky only. September, the size of endometrioma slightly increased, not much, 6 into 4.5 centimeter, 4.9 into 4.5 centimeter on the right side, and the left ovary was almost the same, 2.9 into 3.6 centimeter. So Dr. Krishna, madam, what is the further management for this patient? What will you advise her now?
In this particular case, our main concern in any case of endometriosis is pain, infertility and risk of cancer basically. So in this case, pain is not much as she has dysmenorrhea just for 1 or 2 days. Infertility is a concern and the main concern here would be risk of ovarian malignancy. And we can see that there is increase in the size of endometrioma over last 6 months, though CA125 has reduced slightly. So keeping that thing in mind and age of the patient, I would like to go for endometrioma removal. And here the main concern would be like if there is malignancy, then the complete cystectomy should be done so that we avoid spillage, and there will be histopathology which will give us whether there is malignancy or not, and then we go further.
Yeah, the main concern is that the endometriotic cyst has been persisting as well as recent size increase is there. So these are the factors which should not be ignored in a patient who is having long-standing endometriotic cyst present. So we have to be very careful about these patients. We have to address them surgically and go ahead with the surgery. So Dr. Archana, what preoperative counseling you will do, and if she has decided about fertility preservation, what precautions should be taken during the surgery?
And I would like to thank all the organizers, especially Mala ma'am and Dr. Bindiya for inviting me for this panel. So this pre-operative counseling, of course, we are living in an era of medico-legal. We should be very careful about it. But half of our problem has been solved by this patient by deciding against the fertility. So now we are concerned, and symptom-wise also she is not very bad. She is having some pain, not that much. Her primary concern is about this endometrioma, and she has decided wisely to get a operative management for that. So most probably most of us will be taking this patient by laparoscopy. The endometriomas are not very large. They can be removed. And she has been worked up well. So while taking the patient for this thing, she is only 38. So there is some time for menopause. So first thing we have to tell her about the recurrence. So it may recur, 30% of the patients do recur. It can be reduced to 1/3 by the use of, because presently we are thinking about only endometrioma removal. We have not decided anything else. So Mirena can be one option, Dynagest can be one option. We can have this GnRH analog, and all these things has to be told. All the pros and cons of surgery, laparoscopy, because endometriosis distorts anatomy, there may be complications and risk of anesthesia, and all these things has to be talked at length. And last but not the least is the risk of malignancy. So At present, we are not suspecting anything very wrong in this patient because CA125 has also decreased to 28. So we have to tell her, because you are having a long-standing endometriosis, there is less than 1% chance of having a low-grade serous carcinoma, or it may be endometrioid carcinoma or clear cell carcinoma. There can be there. But you are also infertile, nulliparous, and have been to the ovulation induction drugs, which makes you relative risk of 2.4, 2.7, and 0.9%. Then rest of the woman, it has to be talked with the couple at length that there may be a malignancy in this patient, and there are certain carcinomas which are more prone for this patient. And she has to be told about all these things, and we have to work up very in a nice way. Do examination by yourself, evaluate all the imaging, and have a plan chalk out in your mind. In this case, it has not been written, but if there is any suspicion of involvement of ureter, distortion of anatomy, it's better to have a stenting or trans-eliminating stents may be there. And if you have facility of Firefly, then you will be using that in surgery. And bowel preparation, I personally prefer in laparoscopy case, and I prefer to do all my laparoscopy case first case in the mornings before the patient engulfs a lot of air. So if bowel is there, you should be this thing. You should be careful about this. And operative thing is a very large thing, but I would like to summarize in this patient specifically. You should be take an informed consent of all the organ damage, all the risk of laparoscopy, ureter, bladder, bowel, difficult entry, all those things has to be explained to her. The second thing is documentation, very important. Nowadays we can have a CD of whole surgery, and whatever you are writing in your notes is very important. And the thing is that choose your ports wisely. Preoperative bowel preparation, stenting, whatever you think is important, go ahead with it. Don't hesitate, because after that you will be only responsible for everything. And after port placement, and you may use Palmer's point, Jen's point, whatever you are comfortable with. Before starting anything, you go ahead. If there is any peritoneal fluid or cytology can be taken, you should take it. Inspect the pelvis well. You can have an automatic grasper in your non-dominant hand, and you should see where is the retraction of bowel, there is any peritoneal implants. In this patient, there can be a risk of malignancy if there are implants. Kindly, instead of fulgurating, try to take an excisional biopsy, because if on frozen section you encounter a malignancy, then presence of invasive peritoneal implants will upgrade the disease. So whatever needs to be fulgurated should be fulgurated. Whatever can be excised, you should be excising it. Then see endometrioma, and please send histopathology. If you are able to take out the cyst in toto, in an endo bag, very nice thing. Even if spillage occurs, try to contain it, do a suction, then insert your scope inside the cyst wall. See for new vascularization, see if there is any vegetation, see if there is anything like papillary projection. It will give you a hint that you are dealing with something else. It's not just a simple endometrioma. And bowel retraction, there may be a nodule behind it. So just do a good pelvic examination laparoscopically, and energy sources, it's up to you. You may use electrosurgical or cautery, but it has got a widespread energy dissipation. So in case there is any suspicion of damage to the ureter, kindly trace whole pelvic, course of the pelvic ureter. And then with electrocautery, there is a little bit problem with the planes are lost, and there is widespread spread of the energy. So you may use an argon laser, carbon dioxide laser, whatever you are comfortable with. Even sharp scissors are good enough if you are doing cystectomy. Some people like to have hydrodissection, that is pitocin in 300 ml of normal saline and injecting it so that it makes a good plane. And whatever comes out, you have to send it to for frozen. And if it comes out the peritoneal implants are also positive, then discuss with the relatives whether they want a second look surgery or whether they want to complete the surgery in the same sitting.
So right and left ovarian cystectomy was done, care was taken, no spillage, peritoneal washings were taken, the cysts were kept in endo bag, removed through the left port, cyst wall was thickened, there was small papillary projection in the right cyst wall, and it was sent for frozen. The frozen comes as adenocarcinoma. So what next? Relatives were informed. As Dr. Archana said, if the frozen comes as malignancy, you have to inform the relatives, and decision was taken for completion surgery in the second setting. The relatives said, no completion surgery at this setting, you have to do the completion surgery in the second sitting. So after 3 weeks, the completion surgery was done, laparotomy, followed by total abdominal hysterectomy, bilateral salpingo-oophorectomy, pelvic and para-aortic lymphadenectomy, and omentectomy was done. Histopathology comes as low-grade serous carcinoma bilateral ovaries. Tumor size right ovary 4 into 2 into 2 centimeter, left ovary 3 into 2.5 into 0.8 centimeters. Endometrium, hyperplasia without atypia, omentum negative, pelvic nodes 0 by 12, para-aortic nodes 0 by 5, peritoneal cytology negative. Immunohistochemistry, ER positive 100%, PR positive intermediate 55%, and the stage was assigned as 1C2. So, Dr. Paki, what is the risk of cancer in women with endometriosis, and what information should be provided by clinicians to patients regarding endometriosis associated ovarian cancer?
So endometriosis, there are 2 things. One is endometrioma and the other is deep infiltrating endometriosis and peritoneal implants. So first of all, it is the endometrioma which is associated with malignancy, not the implants and the deep infiltrating disease. The risk of harboring occult carcinoma within an endometrioma is less than 1%. It's 0.8%. So if we have 1,000 patients of endometriosis, theoretically 8 out of those 1,000 could be harboring a silent malignancy and not know about it. Second thing about this is that they do transform. There is a malignant transformation that occurs. In premenopausal patients, it is 1% of the patients, and in postmenopausal, it is 1 to 2.5% of the patients will, the endometriosis, the pathology can transform into a malignancy. Where that is seen most commonly is in patients who are over the age of 45, those who have had a rapid growth of the endometrioma. So those are the women who are at risk. But now when we say the kind of cancers which are associated with endometriosis, there are basically 3. One is the endometrioid, the other is the clear cell variant, and the third is the low-grade serous carcinoma. Overall, the relative risk of any of these developing is 2 to 3 times. That is relative risk. So, but if we say in absolute numbers, then it is 2 cases per 1,000 women followed up over a period of 10 years. So it's not alarmingly high, but it is something that we should know about. So that is why it is not that we say endometriosis is a pre-malignant condition or we do some special screenings to diagnose cancer in endometriosis, because if you see the absolute numbers are just 2 per 1,000 women. But still it is something that we need to counsel the relatives, because here the endometriomas have grown fairly rapidly in size, even though, and again CA125 is not a very reliable marker to predict whether this endometrioma has undergone a malignant transformation. It's not reliable, but yes, if we find a value which is over 200, we would say that something is going wrong there. But other than that...
So Dr. Kanika, are there any tests or biomarkers for better preoperative prediction of cancer in endometriosis? How useful is CA125 in endometriosis? Should women with endometriosis be monitored for malignancy? Especially I'm putting this question because nowadays there is a high incidence of infertility and patients are presenting with many incidents of endometriosis. So do we counsel them with this point of view as well?
So definitely basic counseling is a must for all endometriosis patients, and as far as any other test that we could have possibly added for her, I think an MRI, possibly it gives a better delineation of any solid areas or papillary projections better than ultrasound. Then in terms of biomarkers for prediction of cancer, CA125, as Dr. Paki has already mentioned, is not a very reliable marker, and a lot of studies have, in fact, found a negative correlation. So the lesser the CA125, the higher the chances of cancer, whatever retrospective analysis have been done. Then another, so RMI being the test that utilizes primarily CA125 is not a very good marker. Roma analysis, on the other hand, which uses HE4 as well as CA125 and the postmenopausal status of a woman, has a higher sensitivity and specificity like in any other woman. So not specifically for endometriosis, in a general population also, Roma has known to be having a higher sensitivity and specificity than RMI. So Roma is the preferred method, and HE4 levels are not affected by endometriosis as such. So definitely a better test, and an MRI would be another investigation.
Dr. Krishna, does the use of hormone treatment increase the risk of cancer, and does surgery for endometriosis change the future risk of ovarian cancer?
Yeah, so mostly the hormone treatment is in the form of COC and progestin and GnRH analog, and they does not increase the risk, rather they are protective in for cancer. So it has been said that if the woman takes COC for 5 years, a patient of endometriosis, the risk is reduced by 23%. So they are protective, and they can be safely given. Regarding surgery, it is again, there is no increased risk if surgery is performed for endometrioma. Rather, it is said that if a patient undergoes tubectomy, it is protective, and opportunistic salpingectomy is protective for cancer in these patients.
Dr. Archana, any adjuvant treatment and follow-up for this patient? And we have finished with this case now.
Yeah, Dr. Bindiya, I think because 1C2 is the situation, so NCCN guidelines are very clear about it. You can observe, but this patient has already decided against fertility, and I think she will agree upon chemotherapy, so we can give her paclitaxel and carboplatin. So we can give paclitaxel 175 meters square on day 1 and carboplatin 5 to 6 AUC on day 1, and after 21 days one cycle can be repeated, 3 to 6 cycles. This endocrine therapy, as we have already been clear, because she is ER/PR positive, so it will be beneficial only. So aromatase inhibitors can be given, tamoxifen can be given, leuprolide can be given, even all these things are beneficial for the patient. But not that much up to that extent of chemotherapy. And maintenance therapy with bevacizumab, although ICON 7 and GOG 218 trial has been there, but they are underpowered to make any assertive statement regarding this. So at present, these 4 things can be done, and it can be explained to the patient if she is ready for chemotherapy. Then I think I will go ahead with the chemotherapy in this case, and follow up like every patient. She has to be told that she is a young patient, low grade, this serous carcinoma. So good survival rate is there, but risk of recurrence is there. As any other patient, I would like to call her from 3 to 4 monthly for first 2 to 3 years, and then 6 monthly for next 3 years, and then yearly. So there are recurrences as high as, some literature say as high as 80%, but these patients do well because they can, that they fare well with this chemotherapy. That's why the chances of survival are good for this patient.
Okay, so thanks, Dr. Archana. So this patient went ahead with chemotherapy, and she's completed her course of chemotherapy on follow-up. So with this we finish the case. Rupinda ma'am, please will you like to give some comments for this case?
Good morning everyone, and thank you for having me here. Now there are a few points that I would just like to make. One is that we often get patients of endometriosis, and they are quite concerned that do they have cancer or do they not. So when we clinically examine such a patient, any nodular POD is a red flag. That is very important. No, regardless of, I mean, we've extensively gone through all the theory that so much percentage, this, that, and the other, that is one. Secondly, I would address a patient of endometriosis who is having all this long history, this, that, and the other, more with open surgery than laparoscopy. And if at all they want minimal access surgery, robotic surgery would be better. And in that instance also, I would try to make sure that we do have frozen section, and do a frozen section, and there and then do the, whatever you people are calling second surgery. So we would do a completion surgery there and then, and remembering that it is it is got the chances of being, most important is the low-grade serous carcinomas, because the treatment number 1, 2 and 3 for a low-grade serous carcinoma is surgery. They do not respond to chemotherapy. There is absolutely no clinical evidence, no RCT to prove that chemotherapy is beneficial for a low-grade serous carcinoma. They keep recurring. You have to counsel the patient that we are giving you chemotherapy because that is the norm, full stop. Not that you are likely to benefit, number 1. Number 2, vigilance is very important for you because this cancer is going to recur, but you might not die from this cancer if you are early enough and we are able to do repeated surgeries for you. Number 3, she is young, so you can give her leuprolide after doing the surgery, that as maintenance therapy. If she would have been older, we would have given her letrozole as maintenance therapy. So all these things have to be explained to the patient, and you have to do a full staging laparotomy as has been done. So that's very good. Many times, people just tend to, and I think her uterus has been left behind, or you took out the uterus?
Removed.
Yeah.
Completion surgery.
Absolutely. So that is what is the most important thing about an endometrioma or any kind of cancer that you might come across. If it does turn out to be endometrioid or clear cell carcinoma again has a worse prognosis than your high-grade serous carcinomas. So you have to again counsel the patient. They of course will get the regular 6 cycles of chemotherapy followed by follow-up and all that. So I think that's all I want to say. Thank you.
Can I just make
sure, Dr.
share
Srivastava.
an experience? Very recently, I've operated on a lady who had unopposed Dynogest for 3.5 years. She was prescribed only for 3 months. But as we know that over-the-counter medication is very, very common in our situation, she continuously had Dynogest for 3.5 years and presented with irregular spotting. It is when that time she decided to see her gynecologist back, and there was a small polypoidal lesion at the os, which was biopsied, and it turned out to be a papillary serous endocervical carcinoma. So then she was referred to me. When I evaluated, we have to know that molecular oncology is really creeping into gyne-oncology as well. So many endometriosis associated malignancies are P53 positive. They have loss of heterozygosity, and they have a lot of other molecular mutations. Now, when we tested this tissue, she was P53 positive. We did a metastatic workup. I operated. She's receiving chemotherapy. So we are still getting more and more malignancies with endometriosis. So our data probably in the next 5 to 8 years will change. There was a traditional teaching that the chances of malignancy in a woman with endometriosis is very low. But I think that less than 1% is very likely to be changed in the next 5 to 8 years. When we report such cases more and more into literature, I think reporting of such cases is very critical. Number 2, this patient clearly had increase in size of endometriomas, and we must, suspect malignancy right away. So I also agree with Dr. Rupinder that I would have probably thought of only doing an open surgery at that time, remove the larger ovary, because she has decided not to preserve fertility. So do a unilateral salpingoophorectomy at that time, and do a pre-op MRI, because that helps you to identify papillary projections prior to surgery. And this is probably the way we could, improve our outcome. We could prevent upstaging of disease, and maybe in this situation we would have a disease only at 1A or 1B and not at 1C2. So I think that is something that we need to take away from this case.
Okay. So
Just one thing I want to add. Having said all of this, let us not get knife happy. Let us not say that the patient has decided that her ovary is to be removed. That is a decision all of us have to take. She would not know that it is cardioprotective, that she would not know about the bone health and all this. So I'm all for preserving the ovary as and when, how much of the ovary, little bit, tiny bit, small bit, whatever else you can preserve. You should definitely try to preserve, and even when you are sending for frozen section, and even if it turns out to be borderline, you should still be able to do a staging laparotomy and still be able to preserve any amount of ovary that you possibly can. Thank you.
So thank you very much, ma'am, for the excellent take-home messages. So any long-standing endometrioma, 40-ish, so we should be, it's a red flag sign, and we should not just continue with medical management. We should definitely go in for surgery and accordingly take our decisions depending on the surgical findings and intra-op findings. So I think we are short for the short of time for the second case. So we will rush through the second case, and Dr. Vandana said this, you just rush through it. And so, okay, so this was a 40 years old lady with history of infertility again, and she had a history of myomectomy 6 years back. She presented to us just 2 months back with history of pain abdomen and abdominal distension and known hypothyroid, and her sister had CA breast. On examination, okay, so this started again. Thank you. So on examination, the vitals were stable. The only significant finding was a firm 22 weeks size mass which was felt per abdomen and firm in consistency and mobile. And this mass could only be tipped on the vaginal examination. Uterus was normal. And on investigations, her tumor marker CA125 was 250. Rest of them were all negative. And so the question was, as Dr. Srupender has already said, what are the clinical features and examination findings that we need to look for in malignant ovarian mass? And very rightly, ma'am said, any nodularity in the pouch of Douglas and puckering in the pouch of Douglas should be one of the red flag signs. We should know that yes, this mass may be malignant. And so coming to the clinical features, if Dr. Krishna can just just quickly tell us.
All the clinical features like age, nulliparity status, treatment of infertility, and then the firmness of the mass, history of breast carcinoma in one of the first degree relative, and of course CA125 more than 200, all point towards malignancy. Clinical features are pointing towards malignancy.
Okay. Yeah, so this was a Goff symptom index which we should all know about, and just a bit about how to differentiate the benign and malignant ovarian masses on ultrasound. We are all familiar with the iota, we are all familiar with the B rules and the M rules, and this is how we apply the B and the M rules, that if one or more M rules is there, it is malignant, if one or more B rules, then benign, and if it's inconclusive, then it is the indication for going for an MRI. So these are some other logistic regression models. Other staging systems are GIRADS, and the ORADS is the recent one which everybody is following, and anything ORADS 4 or 5, it is suggestive of malignancy, and we should definitely be very alert, and these cases should be handled by a gynec oncologist. So in this case, the uterus was normal size and the left ovary was normal, but right ovary there was this big mass which is multiloculated, and there were some solid areas also in this. So then again coming to the tumor markers. So tumor markers in this, as we all know, CA125 was elevated, and we've discussed in detail the Roma and HE4 is very more specific for ovarian as compared to the other CA125 alone. So other tumor markers like CEA, CA199 should be done, especially when you're suspecting a gastric malignancy or their bilateral masses. Germ cell markers, we all are aware about HCG, AFP, CA125 and beta HCG together. Any young lady coming less than 40 years with ovarian masses should be screened for these germ cell tumor markers also. And then we have some sex-caused stromal tumor markers. And there's certain combined algorithms also available, especially most we are using this IOTA Adnex model. RMI is also useful. It has been the most common used algorithm, and in which, especially for the postmenopausal ladies, especially for triaging the ovarian masses. And the IOTA Adnex model, very simple model. It comes as an algorithm. You can just feed in your findings, and it will tell you the relative risk, how much is the risk of malignancy, and what is the type of malignancy, whether it is borderline, whether it is stage 1, stage 2 to 4, or metastatic. So very useful algorithm, and in our hospital, we are using it routinely. We use ORADS and IOTA Adnex model to triage the ovarian masses. So again, the triaging pathway, as I just said, that anything which is RMI more than 200, ORADS 4 to 5, Adnex, whenever you're suspecting malignancy, heart fixed pelvic masses with nodularities, these are the masses which should be managed by a gynec oncologist. So in this patient, there was CT scan was done, in which this was a huge mass which was reaching up to the anterior abdominal wall, displacing the Bauer loops and all. And there was some minimal, there was some distal ureter calculi also. So staging laparotomy was done with completion surgery, infracoelicomentectomy, biopsies, TH, BSO, and frozen revealed a serious borderline tumor. And however, the final histopathology suggested a serous ovarian cancer, and it was a stage 1A. So again, there's not much of concordance between the frozen and the final histopathology in ovarian masses. So with this, the second case is over. Now I will like to ask my experts to give the comment on this case. Rupinder ma'am and Dr. Swasti.